get this boat in the waters now. Good evening, everyone, once again. Thank you so much for joining us this evening. So let me start by introducing myself for those that are seeing me for the first time. My name is Dr. Queen Ramorasi, and tonight we are gathered here essentially because we want to learn about diagnostic radiology. And I think it's one of those disciplines that most of us, I mean, at least where I studied, it was never a rotation. So I never got the opportunity to actually go and learn what radiologists do. But I'm sure because we book scans, x-rays and whatnot, I did make a trip down to radiology. But it's also very interesting for me to actually learn more about radiology. In terms of radiology as a career of choice, what does it entail? How do you actually qualify as one? What are the steps? But so far, radiology has been one of my favorite places to just go once in a while, where I work. So we have the privilege today of having Dr. Gopolang Mndebele. She is a pediatric neuroradiologist. So she will take us through the journey of what does it take to actually become a diagnostic radiology or even subspecialize in neuroradiology. So I'm super excited and I'm sure everyone is. Dr. Mndebele, let me take the opportunity and welcome you. You can say hello to everyone and then you can start. So she'll do like a mini presentation and then right at the end, we'll have a small Q&A session should she not cover some of the questions that you guys have. Dr. Mndebele, over to you.
Welcome to everybody, and thank you so much for joining us. And thank you, Queen, for introducing me. I will, as Queen say, just talk a bit about the career in radiology and what it actually looks like to try get into the radiology program. And yeah, radiology is busy. A very beautiful specialty to join, and I might be biased because that's my specialty or my discipline. As Queen has said, I am Dr. Gopolang Mndebele. I am a pediatric neuroradiologist and the current head of unit of radiology at the Nelson Mandela Children's Hospital. My journey with radiology started at community service, where I not necessarily discovered radiology, but I was a bit inquisitive and, got the opportunity, I'd say, to do 6 months of my rotation in radiology. It was peds and radiology, and that's why I ended up in pediatric radiology. And then after that, I went and did my registrar time at Dr. George Mukari Academic Hospital for the first 2 years, and then I did my last 3 years at Wits. I transferred for personal reasons. And then I worked at Chris Hani Baragwanath for 2 years. Thereafter, I went to join the Nelson Mandela Children's Hospital. Got the opportunity through the Sick Kids Foundation to go to Toronto, Canada, to do a 1-year fellowship in pediatric neuroradiology. And then I returned, and in 2023, I returned in 2022, August 2023. I then got appointed and promoted to the head of unit in radiology. So a bit of fun before we get into the detail. People often picture radiology as, beautiful remote reporting from the beach with your laptop and having a nice coconut drink in your hand. But the reality is there is high volumes, there's a lot of work during the night, weekend on call, complex, critical cases and decisions that need to be made, and a very huge legal responsibility for those reports. Before, I would say radiology was quite protected, from medical legal cases. But of late, because I also have an interest in medical legal radiology, there are a lot of cases that are being picked up. And people say, but the radiologist directed me and this is why I did it. So yeah, it's becoming, it is intensive. So what will we cover? Queen gave me a few of the questions to go through. There's 9 of them. What is radiology? Speak on the subspecialties and where to train in South Africa. How does one become a radiologist? Preparing your CV for registrar post. What registrar training is really like, and where can you train? I think I repeated myself. And surviving and finishing the MEd, triumphs and challenges of the career and the business side, state, private, or teleradiology. As a radiologist, we often think just one more case, but in reality, the pile always picks up, or your workstation never clears. So when you go out, someone else takes over because there's always work for us. So let's begin with where it all started, the first X-ray. Rottingen was fiddling with a cathode. That's that equipment he has in his hand. And this was in 8th of November, 1895, when he noticed an unexplained claw. And then he x-rayed his wife's hands. Apparently, when the wife saw her own skeleton, she said, "I have seen my own death." And that's where the first image was created, where we see her hand, even with the ring on her finger. So every year on the 8th of November, every radiography or radiology department takes a moment to pause and reflect and celebrate the work that we do as radiographers as well as radiologists. I always say every patient that walks in the hospital will visit the radiology department. And if they don't come to us, we will definitely go to them via mobile imaging. So radiology is the branch of medicine, and it uses imaging technology, the X-ray, the CT, ultrasound, MRI, and image-guided interventions. So we detect, we characterize, and now we treat the disease. So in honesty, I think radiology is the new medicine because we go hand in hand with every department. So we image head to toe, every region, every system, every aspect of the body. And internationally, actually, there's a lot of sub-specialization with every area that I have mentioned on the slide. But as yet, South Africa, we're not on par. But I will explain that later. So the different imaging modalities, we have plain radiography. I think most of you guys have gone to book a CT scan before. It uses radiation. It is used for chest infections, foreign bodies, and it's quite easy, accessible, and quite cheap. And it's sometimes it's just a screening tool for us to decide whether or not we need to move to the next cross-sectional imaging or not. Then fluoroscopy, this uses real-time continuous X-rays and with contrast. So it's almost like you're looking at the function of that area or you're trying to find out where the region of pathology is. It's usually used for like barium meals, swallows, as well as enemas, for us to look at the bowel loops internally. And then HSGs as well, quite good at that for us to look at the uterus as well as the fallopian tubes, see if they're patent or not. And now it's also used and it helps in whether joint injections, the spinal, even doing a lumbar puncture sometimes if there's difficulty in obtaining a lumbar puncture in the ward, and to check if the lines that have been inserted are in correct positions. And then ultrasound, it uses high frequency sound waves, very good for solid organs as a screening tool. So we can see gallstones, good for, we all know, pregnancy and other soft tissue areas, and ultrasound guided biopsies or interventions are also quite used. It's first line in pediatrics. So most of the time before we go and do a CT, if we can get an answer from the ultrasound, we would use that. Then we come to cross-sectional imaging, CT scan. CT scan, we know it's fast. High dose of radiation, yes, but patient goes in and out. It's used a lot, obviously, in emergency centers, particularly for, brain fractures. Very good at staging as well, and also for looking at any bowel pathology as well as lung or chest pathology. And then we have MRI, does not use any radiation, uses a magnet with radio waves. It's very good with soft tissue detail. This is what we use at my work, because we do a lot of brain imaging as well as spinal imaging. And then mammography, low dose detected x-rays of the breast is used as a screening tool for examination of the breast. So how does one strengthen their CVs, particularly for registrar posts? Right now, there's such a high demand of people wanting to enter into radiology posts. And I mean, the need is there. We do need radiologists. But the amount of posts are not a lot. I come from a very large circuit, the vet circuit. I mean, we take about 70. We have 70 registrars at a go. So make sure that, because you are in competition or you're going to apply against a lot of people. We get more than 100 applications that come in. Look at what the advertisement is saying, what is required. Ensure that your Z83 is filled accurately. Ensure that you are sending it to the correct link. And do it in time. Everything that they need from that form, you should do, because we lose out on getting very good applicants simply because they haven't done the HR part of the application correctly. So if you get that ticked, then the next thing is try get any radiology exposure you can get. Whether it's during your community service, MO time. I know some hospitals offer MO time, but even that, it's quite competitive. But visit the radiology department, ask questions, when they've given you a scan, go discuss with them, why are you saying this? If they have time, they will definitely respond back and, get to know you. Then you sort of get yourself to get a bit acquainted with the radiology department and the staffing there. I'd say also do your primaries quite early. From the moment you decide I want to do radiology, before you even apply, go do your primaries. You do this with the College of Medicine. You're going to write anatomy as well as physics. So you just need to prepare yourself and get your part ones, because that also is something that we take when we're looking at the different applications. Then research output or write-up of interesting cases. I always say, even when you're in M or wherever you are, you come up with interesting cases. It doesn't have to be a case report under, radiology or imaging. A clinical case report, poster presentations or get yourself involved to just present posters, write up on audits of the department, but just collect cases and try and write up and get your research work noticed. And that is also a tick that you would get when one applies. It favors your CV. So where can you train in South Africa? I think the only university I missed is the University of Limpopo. But all these universities do train radiologists. And as we all know, not all superheroes wear capes. Some of us read images. So the radiology roadmap, um, it's similar to most of the specialities. You first have to qualify as a doctor, go do your internship, um, gain some experience with the community service. Now, usually, when you have MO time, it favors you because we know that you have a bit of stronger clinical background. And then apply for your registrar post. The fellowship or subspecialization is written as 5, but this is actually a pathway more that is followed in the in I think it's the Canadian format, where a reg time also consists of a year of fellowship. Then you become a consultant. Don't rush to the x-rays. The treasure is now you're going to be better at diagnosis so that there's better treatment and better outcome, impacting lives, from just being a good radiologist. What is training like? It is very busy. As I said, every clinical service, emergency, surgery, pediatrics, oncology, internal medicine, depends on imaging. So the volume is high and it keeps rising. We've spoken about the different modalities. The exam, as I said, part 1, your primaries consist of physics as well as anatomy. Then you have part 2, which has written and a rapid reporting component. I'll speak about that a bit later. And then the part 2B, they're called orals, but now instead of the oral, before we used to have orals with images, but now they have what they call long cases. They give a case, and they get a bit of time to write and interpret that case. And there's multiple cases over a 2-day period. And then your MEd dissertation as well. So the learning is a bit steep, but at the end it is rewarding. So as I've said, this is just to reiterate, the workload is high because everybody is, needing imaging. And because we're using the different modalities, every speciality would probably require a service for us to assist them with consolidating diagnosis, so that we can guide their management and therefore get better outcomes for the patients. So I'm just going to speak a bit about the VIS circuits because that's where I am a joint staff. It's a very large circuit. It consists of these 8 hospitals, and the registrars rotate throughout the different hospitals. And I mean, it's broad. It's a broad mix. High imaging volumes at some hospitals, some are not so busy. But it gives one a good on-call experience. Nelson Mandela gives the tertiary subspecialty experience. And we know Bara is a very large and busy hospital. So the volume, the complexity, when I was there, it kept me on my toes and quite grounded. But yeah, our circuit consists on around 70 registrars that go through these different hospitals. So as a junior reg, there's a bit of protected time, 6 months, to just get you orientated with the different modalities. We know that as Queen mentioned, that even from medical school, the radiology people do not rotate in the radiology department, and even in the internship or community service time, people don't really go through. It's not a requirement to go through radiology. So 6 months to just get the junior registrar to go through the basic modalities, preparing them, particularly for calls, because that's where you learn. You are on the floor, you're managing the floor, you call your consultant where you stuck, they'll jump in and help. But you are the one who's accepting the scans, triaging, deciding which one must come first, reporting. So you have the first 6 months to learn that. We introduce to fluoroscopy first, and then ultrasound, then CT, and then you add on to the other modalities. But we're ensuring that one is a bit comfortable before they start taking over and making some of the critical decisions. Then we also introduced to rapid reporting. So rapid reporting is one of the exam components. It's almost like anti-mini cases. So it's single-based answer on radiography X-ray images. For example, you could get a X-ray that shows pneumoperitoneum. One needs to be able to pick that up, and there's I think 60 minutes in which 60 cases need to be rapidly reported on. And short and long cases, I think short have now been removed because they've recently changed the part 2 exam to just 2 days of long cases, and they've removed the short cases component. But we start the registrars as they enter to introduce to that. And then once you intermediate to senior registrar, you start even, being in charge of the CT and assisting the juniors. You get now to rotate into MRI, mammography, pediatrics, and some of the subspecialties, intervention, neurointervention. And I think this is the part where people start realizing which direction, in terms of their love for radiology, they would go. And of course, we are the most popular doctors that you never see because we love the dark. In summary, training of radiology is progressive. It's a progressive journey. As I said, in our circuit, we start with X-rays, fluoroscopy, ultrasound, and the basics and CTs, and then you go to the more complex modalities and the subspecialties. The academic program, so we have an online, it started at 4 years, but now I think they are changing the period of time of reg time to around 5 years. But our program started, it's a 4-year program, and it's system-based, going through every system of the body. And there you also, the registrars have quarterly assessment. It's a very good platform where we assess and we see how the registrars are doing, who are the strongest, who need a bit of assistance, a bit of guidance, and perhaps which system are people struggling in. We also give formal lectures that are given monthly, and I think they try to follow the system of the academic the Olwazi academic platform. If they're doing a particular system in the chest, they'll probably try give lectures under that system. And journal presentations, I think it depends which hospital you are in. Some hospitals still do journal presentations, and on-site teaching. Every hospital has the responsibility to teach the registrars that are rotating there. Some have formal programs. We, for example, have learning pathways at NMCH, where the reg logs in, looks at different cases, and then we have a discussion. But also on the day as they're working, we go through cases together and discuss, and that's how they learn. And consults, case-based discussions, multidisciplinary meetings. We know that's the best way to learn, because you also get feedback on whether or not we did get to the right diagnosis, or whether or not we need to go review and also get better history and see whether or not this can direct us to change the trajectory we made with the first diagnosis. So just a quick one on my experience, because I had two different institutions that I went in. At Medunsa, it's formerly known as Medunsa. It's Sefako Makato. It was a more smaller program with, I would say, a bit of strong mentorship, because it was not as busy. We had more time to the cases. It's a good environment to build confidence and foundation, and the calls were not as hectic. Then I went to Bara, the Wits circuit. I think my first rotation was in Bara, so it was a bit of a change and a bit of a shock, the high volumes, And then also there's the multiple hospitals, but wow, the broader the pathology, because I went to the different hospitals and you get different patient profile. There's intense call exposure, but it kept me on my feet. Very different environment, but both of them were quite rewarding. The smaller center had more depth, I would say. The bigger center had volume and forced me to build on my speed. So if you have an option, you look and see which program works for you. But I think now, because of the fact that there is such a high demand in people coming in, you go where you are accepted. As radiologists say, every picture tells a story, but you need to know how to read it. And that's why one would specialize in radiology. So surviving and finishing the MEd, particularly doing it on time. I always say start early, work on your protocol the minute you have a supervisor as well as a topic. Look for the topic yourself and try, when you go to a supervisor, to say, this is what I'm thinking. It makes it easier for a supervisor to also see, let's tweak it this way, or maybe let's change it, or not completely change it, but play around with the topic with you instead of waiting for a supervisor to come and give you a topic. Hence the importance of just getting yourself, when you are like an MO, to just do a bit of research work, present abstracts, so that you get a feel of what are the questions one can ask. You find yourself in the department, you must just start looking, okay, where is the problem? Because where there's a problem, there's probably a research question and research that we can come up with. I say find a supportive supervisor. Sometimes you don't have a choice, because if there is such a shortage, especially in state, of consultants right now. If you have a supervisor, just try to do the best you can so that your supervisor can just give you guidance and you can go through your project. Work on your project timelessly or weekly. We give our registrars a half day a week to do, their research, also to do whatever academic time. Use that time. Don't put it as a rest time, but just sit and try and say, if I work on this every week, firstly, you'll be consistent, and secondly, you will get through as much as you can. And submit drafts early and often. Build in writing time before exams. So with us, we expect protocol adverts, we expect protocol submission, I think they say before the end of the second year. And there must have been submission of the dissertation by the end of fourth year, or just before you go for your exams. And there are various ways where your work can be, or your project can be assessed. I favor publication. because I feel if you've worked on something that the rest of the world see it, but of course you can go the route of marking an oral exam. So the formal subspecialty trainings that we have in South Africa. So as yet, HPCSA has not recognized registration of radiology subspecialties. I think we're still trying to get enough radiologists on the floor for us to then, get to a point where we are subspecializing. So we are, as much as I'm a pediatric neuroradiologist, I am registered as a general radiologist. But we do have a few formal subspecialty trainings. Pediatric radiology, which is done at the University of Cape Town with Red Cross Hospital. There's the neurointerventional radiology fellowship program. This one is done with our Radiology Society of South Africa, SASNI, which is SASNI, which is the subcommittee subgroup of this South African Society of Neurointervention. I think there are there's three national training centers in Joburg, Cape Town, and Durban, and one is expected to go through this Planet course, and then they get presented to the board with their logbooks, and then they would be recognized. And interventional radiology, which is done with Groote at the University of Cape Town. And then, so the question is it worth studying just to become, an expert in pictures? So once you have the FCRAD, as well as the MED, I should have put that in the, registered with the HPCSA, what does this mean for you? There's options. There's state, whether you stay in a public hospital or an academic, a public hospital, contribute to training, but we also know that the state is the backbone of training for all specialities right now. You could join a private practice. It's a bit lucrative, but very heavy and very busy. You could start up your own private practice, but usually I say that they're a bit gate-kept by the larger groups, and it's simply because I think it's also the area in which you're in. If you're in Joburg and there's a hospital that's been built, they'll probably favor those who have already established themselves, So go periphery, start something there where the service is actually also needed. Locums, people do locum for private practices or do sessional work for the state. Mixing it up is also good and very flexible. And teleradiology, this is, has resulted in a very big shift because people love remote reporting. It also has lifestyle flexibility. Some teleradiology practices offer, for someone to choose when they can work and how many hours they like to work. So it's quite attractive. And the triumphs and challenges. So I think, radiology is intellectually stimulating. I learn on the floor all the time. I have to go back. Sometimes I will report an image and realize, oh my gosh, 3 years ago, I did not really know what I was saying. There's so much growth. Or, oh, I missed this one here. Maybe I must be sure that the next time, I put my eye on it. It's constant learning because we are advancing. There's cutting edge technology. Our MRIs are becoming, far better. Now there's the 5 Tesla. We had 3 Tesla. Now there's 5 Tesla. So stronger magnets, getting us very fine and better definition of the imaging region that we are obtaining. lifestyle flexibility depending on what you choose and where you work. There's great earning potential, particularly in the private practice, and it's just constantly evolving. So it's not mundane. We don't remain in the same, place. We know that there's always continuous changes. Challenges, the workload is a lot. Everyone wants imaging, as I say. As you're training, the exam pressure, time that you take to go through your training to get the expertise and MEd dissertation, as we've spoken about. If you go in and you have no idea where to start, it definitely can become a bit of a challenge. And for state hospitals, the equipment and the staffing. Staffing right now is a bit of an issue when it comes to state, and sometimes trying to get these new equipment upgraded and so forth can be a bit of challenge because of the funds and limitations that state hospitals sometimes have. And I just put there, private market is gate kept, particularly by large practices, and one has to adapt to AI. And we must remember, AI will not replace radiologists. I always say it's there to augment the services that we provide. It makes us faster. It helps us, particularly because there's so much high rising workload. So AI is there to help us with all of this workload. And after everything I have said, I dare you to trust me because I am a radiologist. So the take-home message: start early. Use com service time, MO time to get radiology exposure. Sit your primaries before you apply. Write things up: case reports, audits, posters. Anything counts and strengthens your application, and also strengthens your research background. Try, if you have options, choose your training site honestly, but I think right now you apply everywhere and where you get accepted, go for it. I think any place where you get time to train, you can still call on other colleagues if you feel that you just want to get a bit of experience, and then have study buddies and do cross teaching to each other as registrars. Registrars teach a lot. I always say that if I have a senior registrar on the floor who's about to write exams, that is one person that I know I have to learn something from, because they are constantly reading and they're up to date. So you need to, cross teach or cross educate each other from different institutions, because different institutions are stronger with certain pathologies, with the certain ways of approach, and we are all taught differently. Plan your MEd from day one. Half a day a week from, take your time. If you do it weekly, even monthly, you'll just be consistent. By the time you're at year 3, you are submitting your final work. If you can, try pick your subspecialty early. A lot of people are traveling abroad to go and do the subspecialty and come back home, and start different, give back and start different subunits in their hospitals. And then think about your direction, but also there's no pressure. As you are on the floor, you see what you like, and then the options are there. There's state, there's private, locum, teleradiology work. Hybrid careers are becoming common. It's modern medicine, and radiology is a long game. It's very busy, but it remains one of the most intellectually rewarding careers in medicine. And with that, I say thank you. As I said, I'm from the Nelson Mandela Children's Hospital. We are a hybrid hospital. So we do see state patients and we also see private patients. and that is one of our other radiologists, Dr. Gopolang. We currently have advertised a post because the radiologist who was there with that, Dr. Gary, has left to do a fellowship. And so, yeah, if you're around and want to take a peek, you are welcome. But if you have interesting cases, we love to see what we can do or collaborate with others to do write-ups, etc. And with that, I say thank you so much, Queen, for the opportunity, and thank you to everyone who joined in to listen to my short presentation.
Yeah, no, radiology, I must say, I think my impression of radiology, it doesn't actually sound like it is a very supportive working environment. I like your guys' teaching model where, I mean, from MOs to Regios, there's always a consultant to oversee the work that you do in the beginning. So big ups for that, because it's not all or most disciplines that actually have that luxury of having grounding from the beginning from seniors who are very much experienced. So yeah, no, kudos for that. So okay, guys, I think we can go to our Q&A session. If you have any specific question that you want to ask Dr. Mndebele, you are welcome to just put your speaker up. If you're shy, I mean, you shouldn't be shy, but if you're shy, you can just type it for me there, then I'll read it out for you. But if you're brave enough, you can just put your speaker up and ask your question now.
And
Hi.
thank you for this session. It's a so much needed session. I am speaking from Botswana, and I just completed MBBS this year. So I just wanted to know, just to clarify. So she said that the for you to do interventional radiology, you have to start doing it's a subspecialty of radiology. So it's not like you're gonna do diagnostic radiology and then there's another path for interventional radiology, just to understand.
So thank you for the question. So interventional radiology is part of your training. So we have a rotation that the registrars go through as they are doing their radiology block. And then you find those who have interest. For example, I had no interest whatsoever in interventional radiology. I left it when I left Bara and I went to Nelson Mandela. I just fully became a pediatric diagnostic radiologist. But then you have others who then not necessarily subspecialize, but because they have interest in interventional radiology, they then do that. But there is training that we now have in South Africa at Grooteskier, where they are training adult interventional radiology. But for example, like I said, I went to Sick Kids to go get my subspecialty training. So Dr. Gary Pizer, who's now gone to Grooteskier to train for adult, started by doing pediatric interventional radiology and still came back. So it's not that it's separate, you rotate through it. So for example, some people don't do pediatric radiology because they perhaps just do breast imaging. When you are done, I think you sort of have a bit of a direction. But if you're in state, for example, you might be forced to rotate. Some privates have their own people who do certain subspecialty areas and they stick to that. So it's not that it's different and you always have to go do a fellowship training, but I think fellowship training does make you better. And there's you learn so much from that, although most people also learn from the floor. So I hope I answered you pretty.
Yes,
Pretty,
yes,
does
Dr.
that answer the
Gopolang,
question?
thank you.
All
You're
right.
welcome.
Okay. I see a question from Mihlali. I'm just going to read it out quickly. So Mihlali is saying, thank you so much for an informative session. I wanted to ask for someone wanting to get into radiology post, not yet in a radiology post or environment, and is currently working outside of radiology. How would you advise they go about getting an interesting radiology case for a write-up or research to boost their chances of getting a post and improve the CV?
So when you're on the floor and you see an interesting case, you see a radiologist who's reported it, and you ask yourself a question, you can write it up from that point. If you have an interesting clinical case, you write it up and you ask the radiologist to be part of your co-authorization. If you want to do it, if you wanna write up under radiology or imaging. But I think any type of research just gives you a bit of an advantage. The more you get yourself into writing up multiple cases, it strengthens your CV, but also it helps prepare you for the time you have to do your MMed. So it's not specifically that go look for a radiology case to write up, because I mean, if you are not in a radiology department and you are not looking at the imaging, and you're not coming across those interesting cases under radiology, write up the clinical cases that you are coming across. You learn even from there, and you prepare yourself even from there. So yeah, so as I was saying, any research is good research, good for you and good for your CV. So yeah, it doesn't have to be radiology based.
Okay.
I have a question as well from this side. This is Dr. Nkau from Botswana as well. The question I have is about the FC Diagrad Part 1 exam. So, what are the highest yield resources for physics and anatomy that most people in SA use and actually pass the exam with?
Oh, I haven't. The last time I wrote my part one was like literally 9 years ago. Can you drop me an email? Let me get one of my juniors to send you the resources. I mean, I think things have changed. I'm not sure. I'm really not sure what they're using now for both anatomy and physics. And I did my physics with Sefako Makato, which is not the same as the College of Medicine, South Africa. So I did my anatomy with College of Medicine, and then I did my physics with Sefako Makato at that time. And I remember there was this large, big maroon book, but I can get you in contact with one of the juniors that can assist you.
So much for your presentation. It was really informative. I just wanted to ask, with regards to a case presentation specifically, as someone who hasn't really written one up, is there any guidelines that you can give us in terms of where to start with ethics and all of that as well?
So it also depends. It depends where you are and what your hospital what are the channels you have to do to get approved. For example, for us, we go through our academic committee to be allowed to do any presentation or any research work on any of our patients. So you need to find out what is the process or procedure with your hospital, and also go and look at the different cases, like not necessarily cases, but if you're saying you want to write up a case report, Google whatever it is that you want to write up on. See, is there any unique cases or write-ups that have been done? Look at their style. Then look at also would you want to publish this? Because where you want to publish, you need to follow their style, and they'd also tell you when you submit whatever case that you're submitting, to say this is how we would want you to write your case, how to write up your case, and so forth. Also go to your seniors on the floor and say, this is an interesting case. Can you supervise me in writing it up? And they should be able to say, okay, maybe this is where we need to start, and you can also go between different departments. You don't just have to go, if you're in medicine, you don't just have to write up with your senior physicians. You can, whatever the case is, let's say it's a neurosurgical case or neurology case, you can go and co-author with others. Because if you have an interesting case that touches different departments, it also makes it a bit stronger, opens the door for you to also go to different publications.
Okay, thank you so much.
You're welcome.
Okay. And also a detail, if you're just looking at the like the structure, knowing how to go about age rec and whatnot, we do have a research series. It's loaded on our channel on YouTube. I'll load the first video. It takes you, it's a lengthy recording of about 2 hours, but it takes you through the steps so that you can use that as a template while you're preparing your proposal and the process of how to do it. And again, on the 31st of July, we will have a research clinician that will teach us how to do it in this remote hospitals where you don't necessarily have access to academic what can I say, professors and consultants. So go check it out on YouTube. I'll load the second video, but 31st July, you can join to also learn how to do that. All right. I hope that was helpful. Is there any other question from the floor?
Actually, when I say Queen, that's actually so good, because even I use research assistants, because as I'm a clinician, I love the research sciences, but also I don't have time, So I love the fact that you do have at least a YouTube dedicated to research, and there's someone who's coming to give a talk on research, because it's a totally different department on its own.
It can be a nightmare for some of us, but I think if you know the steps, you will actually be able to navigate it earlier on. Okay, and then the question that I had from my side, you did something that I think I've seen a lot of registrars asking about, the process of cross transfer, faculty transfer from one university to another. How does that work if for any other reason you want to cross faculties?
So in the years, there's sometimes a point where the universities say, no, we're not allowed to do that, and they speak among themselves, because when you do the cross transfer, so if there is a post that is open, you can apply. Obviously, the hospital or the university you're applying to will look at you as a strong candidate, because you already have, the basic registrar training, and you might be stronger than the other candidates. But in the time when I did that, it was for personal reasons, because I had just gotten married, so it was easy for me to motivate why I was applying for the move. But you go through the same process. So if you're in Wits and you see a post that's opened at UP and you apply for it, it's at their discretion. But I know there has been, particularly in Gauteng, where there's a period of time where there's an agreement that let's not allow cross transfer, because it causes one hospital, one unit to lose a candidate a strong candidate, if I can say that, because now you've trained someone that, as I was saying, it can be done, it has been done. We've had a few leave the vet circuit to go to different provinces for whatever reason. But also, I think because there is such a high demand for posts, it's also a bit difficult now.
And then the university credits you your time that you've already done, the process of accreditation, so that you don't have to start from point like year one.
It depends on the institution. So when I transferred, they didn't credit the whole 18 months because I ended up finishing in 5 years instead of 4 years. So they credited 6 months from the 18 months that I had done. So it depends on the institution and what their policy is. And for example, there's been people who've come and said, but I already have like a master's, and therefore do I need to do an MEd again? And they make them do an MEd in radiology because it doesn't mean they're going to credit the MEd you've done outside. So it depends on the institution you're going to.
Mm. And also with regard to the dissertation, because you said, I mean, you can do publication, or you can do dissertation with oral exam. Can you just explain how do you go about those two so that people
So
know
there's
options
marking.
that we have?
Yeah, so at FITS, so there's marking where your supervisor has to get you an internal and an external examiner to mark your dissertation, and from there you'll be assessed, and a mark will come from there. Then there is oral defense. There you get 2 internal, I think it's within the university, and you have to go present, and they'll ask you questions, and you orally. I haven't actually seen any of our registrars go through that route, or any of the ones I've supervised. We've either gone through the marking route and the route I love, which is publication, because I feel you've already worked so hard, let the rest of the world see it, and yeah, so then in the case of publication, a lot of the registrars go through SAJR, which is under the RSSA, but I say try international first and see. If we do not get our write-up accepted, then we will downgrade, or not necessarily downgrade, we will then look at our South African journals. So yeah, so those are the 3 options that we have at FITS. I'm not sure about what other options the other institutions have.
Okay. So you can choose either or, essentially, depending on.
Yeah, and also it depends with you and your supervisor. Remember, now your supervisor has to go get you examiners. In VITS, we have such a small pool of we have a small pool of supervisors. We have a small pool of examiners. Then we have to go look for external examiners. Then you have to sit through that process. Publishing just means you look at a journal that you think, okay, do the background research to see whether or not they will accept the type of research you've done. You try. If they reject, you try another one. But sometimes you try and they'll say, no, just change, tweak it, work on it, and then they accept it, and then you do the minor changes and it's accepted. But the research guy will also help you guys when he has the talk as to what's the best way and how to choose the journals, and give you direction onto that.
Yeah, thank you so much for that. I think is that all? The last thing that I wanted to ask for shadowing opportunities, so people can just contact if they want to come shadow, spend a day during leave, just to see what radiology does, just to help with like experience, but also for their CVs. You do have such opportunities there at Nelson Mandela?
We do. You just have to send me an email, and then we'll go through HR. Because they need to know who's in the building at what time. But yeah, it's not a difficult process. It's a matter of sending through the email, then you're filling out the form, and then we can plan on which day would be the best day for one to come and see what we get up to.
No, thank you so much, Dr. Mndebele. I'm not sure, guys, I don't want to close anyone out. Is there any other final questions that you guys have? The opportunities now, before I close the session officially. a thumbs up, like, yeah, we're fine, also would help us gauge whether or not you guys are satisfied with everything. Lovely, lovely. Yeah, no, thank you so much, everyone, for joining. Dr. Mndebele, we appreciate your time. I know you are very busy. Thank you so much for taking time out of your very busy schedule to come and speak to us.
Thank you so much for having me. Thank you for all the questions. Thanks, guys.
All right. Thank you so much, everyone, and good night.